Good afternoon, ladies and gentlemen. My name is Dr. John Abebe, the Medical Director of the Abebe Fertility Center. Today, I'm glad to be taking us through the IVF treatment process at JAFC, that is JOJE Abebe Fertility Center. It's very important for us to do this so that patients can understand what the process is. All right. It's important for us to know that at JOJE Abebe Fertility Center, our IVF treatment programs are carried out following standard protocols. All right, and then these protocols are usually individualized to cope with the medical needs of our patients. No two couples have the same medical profile, and therefore no two couples will have the same treatment program. All right, so we ensure that our treatment programs are individualized, and then to patients to ensure that we have a good outcome. Now, the first process at JOJE Abebe Fertility Center for patients who are coming for IVF treatment is the registration and first consultation. All right, so a form is filled. This can be done either in person or online, and thereafter the registration process would commence. Now, there are some couples who will do both the registration and first consultation at the same time, while some others will do it separately. That means they would have registered before and then come in for their first consultation. Now, the consultation can either be done in person or online, particularly for patients who are not based in Abuja. So for our patients who are not based in Abuja, we offer them an online consultation. Now, this consultation essentially would include getting your medical details, all right? Your medical history is documented, and thereafter you go on to the next stage, which is investigations. And so that consultation will be done by medical experts, all right? So you need to have an appointment booked for that before you can come in for that first consultation. Now, our investigations are generally grouped into 3 packages. We have the basic fertility investigation, we have the standard fertility investigations, and then we have the comprehensive fertility investigations. The basic fertility investigation includes a transvaginal scan, the blood group genotype of both couples, and then the serology test, and then a seminal fluid analysis. While the standard fertility investigation will include all what I've mentioned in the basic, with the hormonal profile test, which will include an AMH, FSH, LH, estradiol, TSH level, and then progesterone. And also, when indicated, we can also do testosterone, DHEA, and prolactin. Now, the comprehensive fertility investigation would include both the basic fertility investigations, the hormonal test, which will basically now include an AMH and TSH, and then other ancillary tests. And the ancillary tests will be full blood count, electrolyte urea and creatinine, liver function test, lipid profile, fasting blood sugar, high vaginal and endocervical swab, and then a pap smear. Now, so these are the different categories of tests that we offer. Now, depending on the patient profile and what will suit the patient, the medical doctor, the specialist will recommend what tests to be done. All right. Now, after the test results have been done, the next stage is fertility investigation review. And this is where the results of the test are reviewed with the patient. The patient is booked an appointment for that. The patient is called, and an appointment is scheduled. All right, and then the patient will come in for that result review. Again, this appointment can either be in person or online. Again, for our patients who are not based in Abuja, they can come in within a day or two, their investigations are done and concluded, and then they can travel back, and within 1 week to 2 weeks of the investigations, the results will be ready, and then they will have their results reviewed. Now, the results are reviewed, and based on the results, the treatment options are discussed, and then we have an agreement. We reach a decision as to what would be the best treatment option for that particular patient. Okay, so it's at that same session that you will have the treatment treatment options discussed. Now, the treatment options could vary depending on the patient's profile, depending on the test results. And for us at JOJE Abebe Fertility Center, we are particular about the option that gives us the best chance of success. So while sometimes the option that may be preferable to the patient may not be the option that will give us the best chance of success. So what we normally will do is to give our patients all the various options and tell them what the success rates are for each of the options, and then together we will decide on what should be the option of choice to proceed with. All right. Now, part of what is also discussed at that session is also pre-IVF treatment. Okay, there are some patients who may require some treatment before the IVF treatment itself begins. For example, patients who would require supplements, either the male or the female, because of the results of the semen analysis or the hormonal test, or patients who require surgical procedures because of the result from the transvaginal scan. Now, these are all discussed at this session. So patients who will need to go through a pre-IVF treatment will know, and then they will commence that prior to commencing their IVF treatment program. Now, so once we have decided what the treatment program is, then a treatment plan, a treatment program is drawn. All right. Now, again, this is it's after the patient has made their payment. Okay. Now, for a lot of our patients right now, they are coming in through the Be Fruitful project. Okay, they are coming in through the Be Fruitful project. So there is a slight change in the order of the process because of those patients who are coming in through the Be Fruitful project. Now, for patients coming in through the Be Fruitful project, once they've registered on the foundation's website and they've had their first consultation, before they come in for their investigations, all right, they would have made the initial payment, the deposit, which is 600,000 right now, and then after that they come in for their investigations. Now, for those who are not doing the hormonals, the investigations are covered right now in the initial payment that is made. For those who are doing the hormonals, they will be required to pay 65,000. All right. After the result review and we have reached a decision on what the treatment options will be, the payment that is now required will now be the additional payment that needs to be paid. For example, a patient who is requiring an egg donation program, all right, that will be an additional cost that will be paid. Or a patient who is requiring an ICSI to be done because of the very low sperm motility and count, that will be an additional cost. Or patients who are, because of age or the test results, will be requiring additional injections, medications above the standard 150 IU that is covered in the main package. All of this will be additional costs that will be taken care of. So once that additional cost is made, then the IVF team will plan the patient's treatment program, and that will be communicated to the patient. All right. So the treatment plan is sent to the patient, and then the patient is called. For those who are not in Abuja, they are called to, and the treatment plan explained to them via phone. For those who are based in Abuja, they will come to the hospital and they have a session with the nurses. All right, so that is done, and then the consent form are signed before the treatment program commences. All right. Of course, for those who are already on pre-IVF treatment, that would continue. All right, before the main program itself takes place. And like I said before, the pre-IVF treatment could be medications or surgical procedures required before the main IVF treatment. Medications to either improve the egg or sperm quality, or surgical procedures like myomectomy, as to remove remove fibroid, or hysteroscopy to remove adhesions inside the womb. Either adhesions, polyp, or submucous fibroids are done. Weight loss is also part of the pre-IVF treatment program that is carried out for some particular patients, because weight can also affect the outcome. The lifestyle modifications, so that you stop alcohol, smoking, and then you reduce stress. Okay. Now, when it comes to the execution of the treatment plan, it's based on the treatment program that has been planned. All right. Typically, most of our patients are given medications to regulate their menstrual cycle so that it falls within the period that we want it to be. All right, because we run our programs in batches every month, and so we want to ensure that patients' program will fall into the period that we want it to fall into. All right, so we use medications like Levofem and Pre-IVF to regulate patients' cycle, and the choice of what medication to use depends on whether the patient is still seeing her monthly flow. For patients who have stopped seeing their period, meaning that they've entered into menopause, Levofem will be the choice of drug to use. While patients who are still seeing their period, we can either use the Levofem or we use the Pre-IVF. All right. And then, of course, the protocols that we adopt, we either use the agonist protocol or the antagonist protocol. All right. So these are a bit more technical, so I probably won't go into depth with this, but just to know that we either use the agonist or the antagonist. Most times we use the agonist protocol, and then in the agonist protocol we either use the long or the short protocol. All right. Now, every patient who is going through IVF must go through what we call a down regulation. Now, what is down regulation? Down regulation means that we give you an injection to suppress your body's hormone. All right, we give you a medication, an injection to suppress your body hormone, so that we can take over the control of your reproductive system. Okay, this is very important, because if this is not done, it will be difficult for us to be able to manipulate your menstrual cycle or your ovulatory cycle, your ovarian cycle. All right, and so that is why you are giving that injection. And so the injections that are given can either be the long-term depot injection, that's the goserelin or Zoladex, or the short-acting daily injection, which is the goserelin. So those are the two injections that are given for down regulation. All right, and in the long protocol agonist down regulation, the Zoladex is given on the 21 of the cycle preceding the cycle of treatment, while in the short protocol you will use the goserelin, and that will be given when the patient sees her period. That's the cycle that we are going to be using for the treatment. And now this injection is continued up until when the patient's eggs are collected, or when there is insemination for patients who are using a donor program. All right. So that is what it's done. Now, it's very important for us to know that when you're giving the long-acting down-regulating agent, it will last for 28 days. And that is usually preferable than the daily injections that patients have to take. Now, for patients who have taken the long-acting down-regulating agent and still require the daily injection, that will be given to you, and then you'll be told the date to start that. All right. So, like I said before, the short-acting, the short agonist protocol usually will start on day 1 to day 3 of the cycle. All right. And the last injection is given on the day of insemination or the day of the trigger for patients who are undergoing stimulation. All right. So that's just a pictorial view of representation of what is done. All right. It's very important that for all patients, before you start stimulation, once you've seen your period, you will go through what we call a mock embryo transfer. Okay. What is mock embryo transfer? Mock embryo transfer simply means carrying out a process that we normally would do on the day of transfer, doing it before that day. All right. Of course, we don't have embryos. Exactly what we'll be doing on the day of transfer, we'll do on that day, just to be sure that there are no challenges. Okay, there are no obstructions, there are no cervical stenosis. All right. If there is any, then it will be sorted out before the day of transfer. We don't want to get to that day of transfer only to realize that the service is not accessible. Now, usually this is done in the office. All right, but in rare occasions when we have difficulty accessing the service, it will be done in the theater. Okay, and once we are done with that process, then controlled ovarian stimulation begins, or endometrial regeneration. Okay, now depending on whether you are a self or a recipient patient. If you are a recipient patient, your donor will start the ovarian stimulation on the day that you also will start your endometrial build-up, the endometrial regeneration. All right. So for patients who are using their eggs, once they've seen their period, stimulation of the ovary commences on day 2 or day 3 of the cycle. And the duration of stimulation is usually for 12 to 14 days. We typically do 12 days of ovarian stimulation. If by the 12th day the patient has not reached the target of 17 mm, all right, we usually will extend the number of days of stimulation until we are sure that the patient has gotten the ovaries are ready for trigger. For the recipient programs, who are on an egg donation program, you would continue with endometrial build-up, and then you come for your scan every week to measure the endometrial thickness. Okay, so that is what is done. Usually, the dose of medication to start with when you want to start your stimulation depends on certain factors. Depends on the age, it depends on the BMI, the ovarian reserve, and then any previous response. So these are what helps us to determine what dose of medication to start with. But typically, the standard dose is between 150 to 225 IU of gonadotropin. The scan is done regularly, usually on day 2, which is the baseline scan, and then day 6, day 8, day 10, and day 12 of the cycle to determine follicular growth and development. All right, and what we use to determine growth and maturity is the measurement of the developing follicle, and the goal is to have at least 3 follicles that have reached at least 17 mm in diameter. So that's what is done. That's a picture of a patient with polycystic ovarian polycystic ovary, all right, just before stimulation begins. Okay. Now the injections that are used for stimulation are gonadotropins. We also do use the FSH, that is the follicle stimulating hormone, either the highly purified or the recombinant FSH is used, and then the gonadotropin, that is the human menopausal gonadotropin. All right, like I said, 12 to 14 days, 10 to 14 days is the duration of stimulation, and then the patient is also given antibiotics. All right, we give all our patients who are going through IVF treatment, we place them prophylactically on antibiotics and also on anti-malaria. Antibiotics, because we know that the rate of infection is very high, all right, particularly in this our environment, and so you don't want to take anything for granted. You may not have made a diagnosis of any infection or have symptoms and signs of infection, but we just go ahead and place all our patients on antibiotics. We also do give anti-malaria, and this also is given because you don't want to be treating malaria early in pregnancy. So these are things that are done prophylactically. So the day 2 scan, which I said is the baseline scan, is to exclude ovarian cyst. The day 6 scan is to check for response. Day 8 is to monitor follicular growth, same also for day 10. And then the 12 scan is to ascertain if the target of at least 17 mm of at least 3 follicles have been achieved. All right. And then once that is done, okay, once we've achieved that target, then the trigger injection, that the HCG, is given. Usually between 5,000 to 10,000 IU is given either intramuscularly or subcutaneously. So these are pictures of developing follicles in an ovary. You can see how big those follicles have become. All right. So part of what the patient would complain, particularly as we get towards the end of the stimulation process, is that she begins to feel pain. The reason why she's feeling this pain is because of the size, the increase in size of the ovary. All right. So for recipients who are on egg donation program, what we do is what we call endometrial regeneration. We don't stimulate them because they are not using their eggs. Okay. So for patients who are not using their eggs, who are on an egg donation program, what we call recipient patients, what we do is to check and monitor their endometrial thickness. All right, their endometrial thickness, and this is usually done after they have had their withdrawal bleeding, after they've had their mock embryo transfer done, and then you start off the endometrial regeneration using estradiol Valerie 2 mg thrice daily. The duration of this is usually from 14 to 21 days. Usually by the 14th day, we should have reached our goal, which is at least 7 mm endometrial thickness with triple line echo. So once we are done with the stimulation, the next thing is egg retrieval. The patient needs to be taken into the theater, and then the eggs are retrieved, or that's for self patient. For the donor, for the recipient patient, the donor is taken to theater and the eggs are retrieved. Like I said before, the patient is counseled on preparation for oocyte retrieval. It's done 36 hours after the HCG trigger. Oocyte retrieval is usually done under anesthesia, general anesthesia. I'm aware that there are some patients who will do oocyte retrieval under light sedation, but what we do is we do it under general anesthesia. And then the patient comes fasting. It's usually done in the mornings, so the patient is told not to eat, and then it's usually for between 20 to 40 minutes. Okay. Now the spouse will produce semen, which are used to inseminate the eggs that have been retrieved. Whether it's a self patient or it's a recipient patient, the spouses of our patient for that day, all of them would come, and then they will produce eggs. So after the process is done, the self-patient would commence the gestone injection. All right, the self-patient will commence the gestone injection after the OCRO, and then same also for the recipient patient. For our recipient patients, we normally will start the gestone injections the next day, not on the day of insemination. And this we do specifically because we want to be sure of what the outcome is. All right, so that is what is done. And then the embryologist later on will give the patient an update on the number of eggs that were retrieved and the number that got fertilized. Usually this report will come the next day after the retrieval. All right, so that is a pictorial representation of what an oocyte retrieval process is all about. Okay, you can see the ovary once again, and you can see that echogenic object that is entering into one of the follicle. That is the needle that drains the follicle and so collect the eggs. After you are done with the oocyte retrieval, they collect the drained fluid are given to the embryologist, who will now screen them and pick up the eggs and keep them. All right. So after the embryo culture, and on day 5 after stimulation is when the transfer is done. So it's important for us to know that we do our embryo transfer on day 5, occasionally on day 3. All right. Patients are usually counseled and given a written document or guidelines for embryo transfer. The patients are informed of the time for the transfer on the morning of the transfer. Please, it's important for patients to note this. We cannot give you a time for the embryo transfer days before the embryo transfer. Yes, we can tell you the date, because you can know your date once you have done egg collection. It's usually 5 days after egg collection. That is when the transfer will be. But as regards the time for the transfer, this will be communicated to you by the nurses on the morning of the transfer. Why? Because the embryologist needs to look at the embryos on the morning of transfer to determine which patient has viable embryos before we go ahead to call the patient. Embryo transfer is usually done under ultrasound guidance, meaning that there must be some urine in the bladder, and it doesn't take long, within 10 to 15 minutes, if there are no challenges encountered along the way. 10 to 15 minutes, embryo transfer would have been done. How many embryos are usually transferred? Between 2 and 3 embryos. If there are any excess embryos, these are frozen. All right, so that's a picture of an embryo transfer. So you can see the catheter, and then just forward, you see that tiny speck. That's representing the embryo that have been transferred. Okay. Now, after the embryo transfer, what happens? The patient is usually given a 14-day appointment to come in for the pregnancy test. For those who are outside Abuja, the pregnancy test is done and the results sent to us. The patients are usually counseled on the outcome. The patients are not allowed to just do their test and that is it. No, we will counsel the patient on the outcome. For those who have positive results, they will continue with their luteal support, which is for 6 weeks. For those with negative results, they will be counseled and encouraged to continue with the program. All right, so that is what is done. Okay, hopefully we believe that will be the results that you will get. 2 lines when you do your results, your test after 2 weeks. Okay, so I want to say thank you very much for your attention. All right, if you have any comments on the process that I've just been explained, please leave those comments down on the comment section, and one of our specialists will get across to you. Thank you very much, and we look forward to having you come into our office to commence your journey to becoming a parent, and we promise you we shall give you an experience that will be most memorable. Thank you. Have a great day.